I wanted to just say a few words about the moment that we're in and the context of this video that you're about to watch. When we shot this video, it was about 3 weeks before the pandemic was what we all know it to be now. It was obviously before social distancing, as you'll see. We're sitting closely together on the couch. We're talking about the Empathy Effect workshop, which for the last few years has been delivered with 20, 25, 30 people in a room together practicing. And now, of course, all of this looks different. And there's a few things about that that I think are really important. The first one is that empathy and skillfully conveying empathy to others is more important than ever. It's more important because we're in a moment where, because we're all going through a similar thing, even though we're all having different responses to it, we're all going through something similar. It's an opportunity for unity, and it's an opportunity for feeling care and connection to others that we might not have been able to feel before. Care that transcends our differences, which is very much what the empathy effect is about. It's also a time where there's a lot of barriers to feeling empathy towards others and to conveying that empathy. For example, many of us can't see people's faces anymore. We see people in masks. And so our ability to see how they're feeling and to convey care with smiles and facial expressions is really inhibited. We often are talking to people on the phone when we would normally see them in person, including in our healthcare visits. So we've lost the ability to convey empathy non-verbally and have to instead rely even more heavily on verbal empathy. So many of the things that are the core principles and practices of the Empathy Effect workshop are really more important than ever during this time. The way of delivering the workshop is quite different. And in fact, as I speak, the Institute for Healthcare Communication and the Health Improvement Partnership of Santa Cruz are both working to figure out how this important workshop can be delivered online. So there's some work to deliver it online in webinars that are shortened instead of long workshops. There's individual trainers who are working out doing interactive webinars. There's a lot of creative and interesting work around how to make sure that this important practice gets out to you all. So we really encourage you at the end to email the Institute for Healthcare Communication or the Health Improvement Partnership of Santa Cruz to find out how you can still access this important work.
Welcome. This video is a partnership between the Central California Alliance for Health, the Health Improvement Partnership, and the Institute for Healthcare Communication. The objective of this video is to introduce viewers to the use of empathic language in day-to-day communication and in healthcare settings. For the next 45 minutes, you will hear from Elizabeth Morrison, Hughes, and Maritza Lara. They share their perspective on the impact of empathy and biased communication in health outcomes, as well as their experience with a training that has been specifically developed to enhance empathic communication skills. This training, titled The Empathy Effect, Countering Bias to Improve Health Outcomes, or EE, is a half-day training that provides an immersive experience for workshop participants. While this video is an introduction to the complete workshop, the accompanying handout to this video contains a space for you to reflect on your own experiences with empathy and bias or judgment. You will also find a 2-page EE skill summary with some of the empathic communication strategies and bias decreasing tools that are discussed in the full workshop. We will be discussing several of these tools during the video. If you want to experience the entire workshop, please contact us.
Hi, my name is Elizabeth Morrison, and I'm here today with my colleagues Maritza Lara and Hughes, and they're my friends too. And I just wanted to talk a little bit today with you both about empathic communication. The workshop The Empathy Effect, Countering Bias to Improve Healthcare Outcomes. I was a co-creator of this workshop. Maritza, you were in a Train the Trainers and are now a trainer yourself and do the workshop in the community. And Holly, you've been a participant in the Empathy Effect workshop. So today I wanted to just talk a little bit about all of our perspectives around this workshop. And we're also going to talk about the research that underlies the workshop, the research around empathy and its impact on healthcare outcomes, and some of the principal strategies of empathic communication. So, Holly and Maritza, can you talk a little bit about what it was like for you as a participant in the Empathy Effect workshop?
Sure, I can share some with you. I was part of the 2017 Train the Trainer cohort. And one of the things that I got to experience while I was going through this training is the actual workshop. And one of those big experiences that I always go back into is, oh, I am feeling all these things as I'm sitting here as a participant. And the training goes from very low risk to higher risk. And because of my experience as a participant in the workshop at first, I have a lot of empathy for the people who are going through the training and I know are going to be experiencing all these questions, and they're going to be putting themselves out there talking about their biases and their beliefs. So I think that it was such a great experience just to be in the driving seat and then also on the companion seat and figuring out, you know, what is it like to be going through this process as a person in the training.
Hearing you say that makes me think about my experience being in therapy as a therapist, right? It's very similar to that. It's I don't think I would be the kind of therapist I am without having sat in the other seat, you know, and with healthcare, we're all patients and we're also providers in this case. And so I think for me, that process of just hearing from my colleagues, the training that I participated in had, I believe, you know, maybe 20 of my colleagues in it from all different disciplines and positions, and some people that I would see but not really talk to. And so for me to hear their stories and just sitting around this big U shape and having the connection happen across the room was really just in and of itself pretty powerful.
The Institute for Healthcare Communication is a nonprofit organization that conducts research, develops learning and development programs, primarily in the area of communication in healthcare. They also conduct workshops and train the trainer courses in the United States and in Canada. The IHC, as it's often referred to, has a long history of developing communication workshops that are research-based and has specifically focused on the evidence base around empathic communication practices in healthcare. This workshop, The Empathy Effect, Countering Bias to Improve Health Outcomes, is a practice-based workshop focusing on empathy, its relationship to better healthcare outcomes, and its particular importance with vulnerable populations. The empathy effect is based on 3 premises. The first one is that empathy is healing and judgment is harmful. There's an enormous research base showing that when people feel empathy from those caring for them, whether it's a parent or a healthcare provider or a therapist, that their health outcomes improve. Empathy in and of itself is healing. Conversely, judgment, which is the opposite of empathy, is actually harmful to people. When we feel judged by another, whether it's someone in our family, a friend, or a healthcare professional, we actually get worse. Our health gets worse. Our diabetes is worse. Our ability to make changes in our food and our exercise programs, for example, deteriorates. Our depression gets worse. There's even research showing that when we feel judged, people with alcohol use disorder drink more. So empathy is healing and judgment is harmful is the underlying premise for the whole empathy effect. The second premise is that vulnerable populations experience greater harm by judgment and lack of empathy. While judgment and lack of empathy is harmful for everyone, vulnerable populations are particularly impacted. When we talk about vulnerable populations, we're talking about groups of people that have conditions or characteristics that have been historically marginalized or judged. For example, those with addictive disorders, people with chronic pain, those with severe mental health conditions, teen mothers, people who are immigrants, people of color, those from the LGBTQ plus community. These are examples of populations that are already vulnerable and already stigmatized. And when they experience a lack of empathy in the helping professions, they're actually more disproportionately harmed. The third premise is that we all have judgments. We all have judgments and biases. In the Empathy Effect workshop, we try to create a safe place where we can all self-reflect on our own biases and judgments without judging ourselves. None of us get through this life. None of us get through the conditioning from our families and society without developing a lot of biases and judgments. And the good news and the reason for this workshop is that we can learn to manage our judgments and improve our empathy conveyance. There may be some judgments and biases that we choose to hang on to, that we want to hang on to, and that, of course, is our choice. Most of us in the helping professions would rather be able to mitigate the great majority of our judgments and biases if it means that we could be of better help to those we're serving. And it's absolutely possible. In the Empathy Effect workshop, we use the acronym IN-GEAR to talk about the process of noticing judgments and biases, mitigating them with evidence-based, what we call counter cues, and employing empathic communication strategies. So noticing judgments and biases is the foundational skill that we talk about in this workshop. Many of us are already practiced at this. Many of us have developed a way of reflecting on our own thoughts, reflecting on our own reactions, and getting an awareness of where our biases lie. For therapists, for mental health therapists, this is something that's deeply important in our education and training to be able to do. Many people do this naturally. The reason that this is so important is that what we know from research is that biases that are implicit, meaning they're unconscious, we don't know we have them, can't be mitigated. We can't do anything with those biases. We just end up acting them out in a sense. Biases that are explicit, biases that become conscious, there's all sorts of tools that we can use to counter and better interact with the people in front of us. We also know that when biases are unacknowledged, they actually become stronger. So when people say, I'm not racist, when people say, I'm the least sexist person, for example, when people deny biases, it actually strengthens them. So part of what we do in the Empathy Effect workshop is we want to create a comfortable, safe environment for people to self-reflect on their own biases and not feel pressured to deny that they have them. After we notice our judgments and biases, then we employ counter cues. Counter cues are very specific strategies that we talk about in the Empathy Effect that can help us mitigate, that can help us counter, that can help us in some way neutralize the bias that we have. The third premise that we talked about, that everyone has biases, one of the things that we do in the Empathy Effect workshop is we talk about all of the places, all of the areas of influence that are responsible really for giving us these biases. Of course, movies and TV, books, all kinds of media that we grew up on is responsible for many of the biases that we have in this country. Just as an example, if we think of the bias against people who are overweight, most of us grew up with movies, TV, books, radio, sitcoms, magazines, really privileging and prioritizing the thin and marginalizing those who are overweight. Sometimes they're portrayed as not as smart, sometimes as lazy. So when we grow up on this for decades, it's no surprise that even if we didn't want it, that we might see that we have some of this. Of course, from our families all have different internal family cultures, and biases typically are passed on in families. If we don't become aware of a bias and make a different decision, we may end up just absorbing our family's biases. Different cultures and religions often have explicitly teach biases. For example, many religions might teach that lesbian, gay, transgender, or people who identify with different sexualities are bad or wrong, are sinners, for example. This is an example of a bias in religion. In schools, workplaces, social media, of course, and our peers. So nobody is exempt from being conditioned in a society, and we all end up with some biases that we might feel defensive of, and many of us end up with biases that we really don't want. In this workshop, we are inviting people to self-reflect on their own, perhaps negative biases about particular groups of people or characteristics in order to become more aware of them and mitigate them. And it's very difficult to ask people to reflect on these things, much less talk about them, if they're not feeling connected to us and the other group members. So the entire workshop sort of rests on the assumption or the ability that we have to really create a safe environment through connection to elicit what you were talking about, Holly, which is to have these coworkers and people that you might not know, that you might know but haven't heard talk this way, share with everybody about their own feelings and thoughts and sometimes experiences of being on the receiving end of negative bias as well as their own biases.
I'll really say it's super magical as a trainer to be able to experience it time and time again. I mean, it's not just one training and then you're done. It's every training that I have been able to conduct. It works every time because people can feel that you genuinely care for them or that you don't. And so sometimes you can feel it, but you don't express it. And I think that through the training, one can really learn how one can express that one cares for the experiences that a stranger had. And it's so quick. I mean, it's just truly 3 seconds, 5 seconds. It's not, 2-minute thing that, oh my goodness, the training now is gonna be late because I'm trying to connect with people in this way. It's truly 3 to 5 seconds.
That's what, Holly, this is what you and I always talk to medical providers about, this idea that often they feel like empathy takes too much time.
Yeah.
So part of the workshop really is speaking to that, is speaking to the fact that we can indeed connect and show deep care and compassion for people in either very little time or the same amount of time that we might have inadvertently conveyed some dismissiveness. Mm-hmm. Holly, can you talk a little bit about your experiences of empathy and or its opposite, bias?
Sure. I think what comes to mind, I have this memory of my son, Benny, who is 12 now, and I adopted him. And he has quite a unique family setup. And when he was in first grade, he was asked to do a family poster. And he brought it home, and it was a very different picture than our family. And so my first reaction was to be upset about that and to wonder, how does this small person, with all of our, teaching and embracing, empathy and equity, how does he come home with this poster that doesn't reflect his family? And then I had to roll that back and see from his perspective that the safest thing for him to do and present was to kind of be like, this is similar to my peers, right? And so we just kind of talked through what was actually, his family set up, and we did some drawing around that. And then the one that he decided to present at school was the one that did not reflect our true family setup. And so I think those are moments where I am just really struck by the fact that it's not just one moment. It's not, bias is kind of in us and around us in such a way that all we can do is be really just kind of increase our awareness and have kind of a grace bubble around it when it shows up, and just keep having dialogue and learning and growing.
Okay. I wanted to just talk a little bit about one of the things that we actually asked participants to do in the workshop, which is to take a minute and just reflect on experiences they've had in healthcare settings, either they themselves or people that they love, their family members, when they have experienced empathic care that's had a significant impact and influence on decisions they made around their own health, or the opposite, when they have felt pretty clearly that they were on the receiving end of implicit or explicit bias, or we could also call it stigma. And one of the things that I think about and sometimes share about is the fact that I was in an emergency room with my husband, who's a recovering person, recovering from addiction. And he was there with severe stomach pain, and he filled out an initial form and marked that he had a history of addiction. He's 33 years clean and sober. And by the time we got to the physician who was assessing him, it was crystal clear within about 30 seconds that this physician wanted nothing to do with my husband. He wanted that interaction over. He was done the minute he started. He did not want to hear the story about the pain. He said repeatedly, interrupting my husband, "We don't do pain here. We don't give pain meds here. You're going to have to go see somebody else. You're not going to get help here." And I didn't know my husband had marked the history of addiction accurately on his health history form. And so as we were leaving, and he disclosed this to me, I just felt so sure. Addictive disorders are so highly stigmatized, and most of us were raised with significant negative bias around addictive disorders. And we know that bias in healthcare, in particular around addictive disorders, is incredibly high. And I think by checking that box, he stepped right into that. And so as a result, of course, not only did he not get care, but then he's made decisions now, which are the same ones that I've made, not to indicate a history of addiction. So essentially to withhold important health information from healthcare providers. So just an example of how bias affects our health decisions. And I'm wondering if both of you could talk a little bit about experiences that you've had in this area.
Yeah, so when you were talking about this, Elizabeth, it just reminded me of my little sister. She's 15 years old now, and I have been raising her for about 5 years. So when she first, came to live with me, and we had all this, okay, we need a primary care provider. Let's figure out, if you have everything in order before you go to school. I remember walking into the doctor's office, and some people will give us these looks of, why would you have a child at this age? Like, are you the mom? Who are you? And in many instances, people wouldn't even ask. They will just go into, well, were there any issues during the pregnancy? And I was like, I don't know. How can you not know? well, and then instead of actually taking a step back and figuring out, oh, maybe you don't know because you're not the mom, it's more of like, you were a very responsible teenager. Why did you do this? And now look, you have this 10-year-old with you, and it was just so hard, to the point that one time my sister said, I don't want to go back to that doctor. Can I not ever see her again? And we had to shift providers because she was just not going to talk to this person that she didn't feel was taking care of her. There is a huge stigma that Latina women have to go through and experience, especially in this country, where there is the belief that, if you're Latina, you're going to have 8 children, and or you don't know what you're talking about. And it didn't really, it was so interesting one time, they provided, and later on found out, oh, not only are you her sister, but you're also a nurse. So you could actually know what I'm talking about. And things really shifted, and the conversation really shifted. And so I think it's twofold for me. It's like knowing that I have biases, but also knowing that other people have biases, and knowing how to forgive that, and how to, okay, I understand that this got in the way, and I want to make sure that we can connect because it's in the best interest of this kid. And also knowing that sometimes it's just, you just shut down because it's too much, and you are just really there to get the treatment that you need. And I don't have time for all this work that I have to do to understand that you are not listening. So that's experiences that I've had.
That's really a good example, what you're describing with your little sister, that we very often make decisions to forego care, to delay care, to not go back, because when we feel that bias, it's really significant harm in that sense. What about you, Holly?
Well, that actually was my experience when I ended up delaying care that was pretty important to get. When, kind of back to what you were saying about how you were perceived, just like that automatic perception, which is how our brains map people just to make sense of our environment, right? It's just, it's not a bad thing. It's actually a skill of ours to be like, okay, I understand what's happening here. And so I think for me, oftentimes, depending on what the setting is, I get mapped as heterosexual. I get mapped inaccurately. And sometimes that's fine, and sometimes it's a little bit more burdensome. In one case, my primary care doctor is a lesbian, and I'm very comfortable going to see her because I don't have to do any explaining. We just start exactly where things are and go from there. And there was a time when she was out, and I saw someone who was filling in for her, and he mapped me inaccurately, and it just went so far in the meeting where he was checking my moles, and he was noticing, oh, you have a lot of moles, and he said, you should make sure that your partner looks at those, and he defaulted to he, and I corrected him and said, well, she, and then he proceeded to say, well, just make sure they check that out. And it was very subtle, but it was just enough for me to kind of file that away. And it's a little bit embarrassing to admit that just kind of subconsciously, I didn't go back to get my moles checked, which I was needing to do that about every 6 months or every year. And by the next time I did go back, I had a mole that had some like pre-melanoma associated with it. So it's one of those experiences that I think the stakes were just really high. And it was unfortunate that it went that way.
That's what judgment does. It really closes the door, and empathy opens it.
Yeah.
That's really unfortunate in your case. It could have gone so much worse, where, you could have gone 2-3 years choosing not to go back, and then it could have costed your life.
Yeah.
And
well, I was just going to say, who knows, just to kind of step into his shoes, this doctor, I have no idea what he was intending, right? It's not necessarily malicious on his part at all. I don't know. Um,
Well, let's move to there.
Yeah.
Because we three have biases too. So we were talking about when we felt on the other end of them. Let's talk for a minute about what we know about ourselves and our own biases. One of the things I'll start that I noticed was I moved to California 15 years ago, and I had always worked in addiction treatment. So when I moved to California, it was the first time I'd ever worked in medical settings. And so it was and I'm also from Alaska, and they do not have state disability. So being in California, working in the medical setting was the very first time that I ever saw patients who would come with disability paperwork. So what happened for me is it took me probably a few months before my bias came to my awareness that what would happen is when somebody who was young, and when I mean young, somebody who was in their 20s or 30s, would come into my office and would have disability paperwork and indicate to me that they were too anxious or too impaired by depression or anxiety, for example, to be able to work, and would I sign their disability paperwork, I realized that I had a lot of judgments about people who were young and didn't work. And what I saw as didn't want to work. Even being a therapist, even understanding how debilitating anxiety and depression could be, it was just about someone who was young and wasn't working. And I had to really unwind where that came from and how it was manifesting in sessions. And what I found was it manifested in me not having a curiosity about the story. As soon as I saw the disability paperwork and matched that to their age, I did not ask more deeply about their experience. I didn't dive in to have them share with me what it was like or what their experience was of not being able to function in a work world. I didn't. My curiosity was gone. And that's one of the signs of bias is we just don't have curiosity in individuals because we've already decided on the story. And it's a single story. There's one story. It's what we also might call a stereotype, I guess. And for me, I'm the kid of immigrants and like many of us, and basically how hard you worked was essentially a perfect proxy measure for how good a person you were. And so, the times that I had 2 or 3 jobs were the times that I was most highly approved of in my family. And they didn't even like the idea of going to college. Why would you go to college when you should be working? Don't you want to work? And so knowing where that bias came from and really understanding it really helped me unwind that conditioning and be able to counter that bias and be able to provide such better service to young people who are in that position of having debilitating mental illnesses. So what about you both? What have you learned about your own biases?
I can try. So again, going back to my youth and my childhood, there is a deep regionalism in Ecuador with the people who live in the coast part of the country and the people who live in the highland part of the country. And we are, people look alike depending where they are, no matter where they are in the country. But the difference, there's a very subtle difference in the accent that we have in Spanish. And so growing up, there was this, the culture around me, TV, will make a lot of fun of people who had an accent that resembled the people from the other region. And so I will hear these things of, we will never marry someone from that region. And this is just 2 hours, a 2-hour drive. You will not marry someone who speaks this way, because then it will mean that you are this, that you're this, that you're this. And I always thought that people from that other region were beautiful. And so it was really confusing for me as a young person to understand, why would you not be with someone or fall in love with someone or even date someone based on the subtle accent that they have. Mm-hmm. Same language, same everything. And so I ended up moving to the US, married someone from here, and I had been able to really go back in my mind and realize that kind of upbringing and that those ideas, those stories, those thoughts all have prevented me from getting to know people, maybe not in a relationship, but even friendship. Or what if I was a provider of healthcare there?
Mm-hmm.
And how will that have an impact on who I thought was deserving of my time? And it really helped me, that story helped me when I moved to the US to really see what other biases that I have not explored, what other beliefs are ingrained in me that I need to really unfold, because as a healthcare provider here, maybe I won't have that issue of, well, if you have an accent, then I feel this way. But what about skin color?
Mm-hmm.
What about sexual orientation? What about religious background? I mean, what other things are already in me that I have not even taken time to explore? Mm-hmm. And that's how I really have been working these past years to figure out who am I more likely to not help or to not listen to because of what I personally believe. Mm-hmm. That's a story.
Some examples of how we might notice our judgments and biases are when thoughts cross our mind. If we can increase our awareness of particular thoughts or thought patterns that come across our mind, we might see that they have been generated by bias. These are examples of counter cues. Counter cues are research-based. All of these have been heavily researched. However, they're not the only counter cues. We're going to talk about 5 in this video. There's 8 in the empathy effect video, and there's countless others that have been researched as well. We talk about a lot of strategies for conveying empathy in the empathy effect. There's an enormous amount of research on communication techniques that successfully convey empathy for most people, and in that sense, improve healthcare outcomes. We all have areas in our lives and particular communication patterns that are very skillful, and we all have a level of awareness and self-reflection about ourselves. And so this workshop isn't really meant to imply that somehow people need to learn, communication skills, or they need to get insight about biases. The workshop is really in some ways to create a space for all of us to be able to take a minute together and notice, really purposefully notice our communication patterns. And where are they most skillful, and with who are they most skillful in terms of really conveying care and empathy? And is there a way to sort of amplify or highlight that? Is there a way to notice when we're really listening deeply, or when we're able to reflect back to somebody what we hear them saying? And once we notice that, can we purposely then practice that in other areas of our lives? And you just reminded me of something that, Holly, you just said to me not too long ago, that this is a sort of a good thing that we don't mention enough, which is the workshop itself, and even our conversation today. What we're not saying is we all need to be more empathic with everyone all the time. That is not what we're saying. It's that when we make a decision that we want to develop an empathic relationship with somebody, whether it's because they're people we love, our partners, our children, our moms, our dads, or whether it's because we work in the healthcare field and we care about the people we're serving and we want to develop empathic relationships with them, and we know that that's how we can be most helpful. When we make a decision, this gives us a framework in which to think about how can we focus and continually improve in that. There are many situations and times and people and conditions where we do not want to have a relationship with people, much less an open, empathic relationship with people. Quite frankly, we don't necessarily want to be vulnerable with them. And when we've assessed that that's the case, there's nothing in this workshop, and there's nobody here who would say to somebody, you should be doing otherwise. Because just like the examples that we shared at the beginning, when we talked about when we felt like we were the recipient of bias, when we feel like that, sometimes it's most important just to self-protect and avoid and move away. And that's an important decision as well.
Well, it's so interesting that you say that, Elizabeth, because one of the things that I frequently hear from participants at the workshop is, I wish everyone was taking this training. And I agree with people. This is a training that will benefit everyone in the organization. There tends to be a belief that only some roles in the organization will benefit from a workshop like this. And truly, everyone in every role, no matter where you are in the organization, benefits from being able to create an experience for patients, an experience where people are feeling connected, where people are feeling like they are being taken care of from the moment they walk into the clinic and even outside, all the way to the moment they receive a bill or when they call and with a question, So I think that it's important for people to build common language.
You can feel very empathic towards someone and not convey it successfully in a way that that person feels it.
So had I quit my job the next day after I have taken that half-day training, I will have benefit from that investment of time. Mm-hmm. So it's not a workshop that you go in and you hear all these things and this is just applicable for your work. This is applicable for your entire life.
One thing we know unequivocally that there's 25 years of research in the medical science field now is that patient experience is tied so closely to patient outcomes that they can actually be proxy measures for each other. So the better patient experiences, the better the health outcomes are. The worse patient experiences are, the worse patient outcomes are. And there's a bunch of reasons why what we think the connection there is. One of the most clear connections is that when patients feel respected, feel cared about, and feel like they trust their healthcare team, they're more apt to adhere to recommendations, period. And when patients adhere to recommendations, their healthcare outcomes improve. So that piece I feel like is deeply important, that if we're in organizations that are receiving care-based incentives, if they're receiving even some reimbursement based on clinical outcomes, then this workshop and the communication strategies outlined here will directly impact those finances.
If you're interested in becoming an Empathy Effect trainer, please email the Institute for Healthcare Communication at info@healthcarecom.org. To find out about options for Empathy Effect trainings in Santa Cruz, Monterey, or Merced counties, please email the Health Improvement Partnership of Santa Cruz County at admin@hipscc.org.